Welcome to Get Briefed Podcast, the latest MDBriefCase group offering developed to inform healthcare practitioners regarding a variety of relevant medical topics. This podcast is available at www.mdbriefcase.com. The views, information, and opinions expressed in this podcast are solely those of the individuals involved and do not represent those of MDBriefCase. This podcast does not constitute medical advice and is only meant to educate and inform the listener. Please enjoy.
I'm Dawn Rae Downton. So far in this podcast series, we've looked at several aspects of chronic pain. We've dissected the so-called opioid crisis to determine what it is, where it came from, and what, if anything, it has to do with pain. We've drilled down into what pain actually is. We've looked at how acute pain differs from chronic pain, maybe in more ways than you might think, and how some acute pain becomes long-term misery and why that might be. We've looked at how to evaluate chronic pain in your patients so that you'll know whether and how to treat it. What we haven't talked about yet is the increasingly dicey question of how exactly to treat chronic pain. Over the past couple of years, many of our family physicians have been wondering whether treating patients with chronic pain is too complicated, too fraught, given the scrutiny they're under from their medical colleges. They've been wondering simply whether it's worth the aggro at all. Listeners, what about you? Do you really have to turn over your pain patients to a pain specialist, especially when they're in increasingly short supply? Today, to lead us through the theory and practice of treating chronic pain, once again, we're joined by two experts who've run the gamut of experience with patients in pain. Alan Kaplan is a family physician in Ontario's York region. He's also a pain consultant and a clinical lecturer at the University of Toronto. Robert Hauptman is a pain consultant practicing in Edmonton. Dr. Hauptman is an assistant clinical professor with the Department of Family Medicine at the University of Alberta. He's also one of the founding members of the Pain Society of Alberta and the Alberta Medical Association's Chronic Pain Section. Dr. Kaplan and Dr. Hauptman, thanks for joining us.
Good morning, Dawn. Thanks for having us along.
Morning, Dawn.
Morning to you guys, too. Dr. Kaplan, I'm going to throw the first question to you. Maybe we need to look at what obligations physicians do or don't have to treat chronic pain. Do you think they have obligations to treat chronic pain from an ethical point of view and also a legal point of view?
Well, to begin with, of course, physicians as a profession started because barbers had to deal with painkillers and dealing with opium. So that's where we all came from as physicians, is managing painkillers. In terms of managing pain and chronic pain as an obligation, well, isn't the major mantra of medicine is to relieve suffering and to do this in a safe way? We used to talk about something called the fifth vital sign, and managing pain is the fifth vital sign to make sure that we're actually managing pain properly for our patients. There's a few dictums of medicine. One of them is that we should cure sometimes, diagnose often, but comfort always. And I think that in chronic pain is one more example of how physicians really are morally obligated to treat pain. The other dictum, of course, is do no harm. We have to make sure that as we're treating pain, we're also doing no harm for both the patient and society.
So I agree. I think that there is an obligation to look at pain in our patients and try to help our patients. I can appreciate that some family doctors feel uncomfortable, particularly treating chronic pain. And it's okay in a sense to be that way. There are many diseases that primary care physicians may be uncomfortable in managing. But what is fundamentally very important in this population is they all need a family physician. And even if that family physician doesn't feel comfortable managing their pain, maybe they haven't had enough training, maybe they don't understand the nuances of treatment, they still have to take care of their primary care needs and refer them, if appropriate, to somebody who can help them. I think one of the real problems in Canada is not only in the treatment of chronic pain by consultants and primary care doctors, is also these patients even getting basic primary care. So I think there's that basic fundamental obligation of physicians to see pain patients, offer them primary care, and then secondarily, if they do have a pain problem, to get them to the ultimate help they need.
Thanks, Dr. Hauptman. Sorry, go ahead, Dr. Kaplan.
I'm just going to say it's as clinicians are being more and more under the gun about managing pain, and I understand the concerns, I think one has to remember that all of us are just one misstep away from significant long-term pain. An accident, a surgery, something that can cause pain that lasts for the rest of your life. And we have to remember that and not forget that any are potentially in this situation.
Right. And I think, Dr. Hauptman, your point about primary care is, I think you were the one who said this on a previous podcast, that we don't talk about that enough, that when a patient is dropped out of primary care because of pain issues, that patient also loses his or her primary care. And we know that there's a shortage of doctors right across Canada. So it's not easy to find a new doctor, particularly one who's willing to take on a patient with pain issues. Just before we leave the question of whether or not clinicians have obligations to patients with pain, do you think it's on the radar, either of you, do you think it's on the radar of most doctors in Canada that we have, that for example, the Canadian Medical Association, a member of the World Medical Association, is obligated under declaration from the World Medical Association to treat pain effectively? We also have a treaty with the UN that says that we will have I think what it says is that we'll have adequate narcotics on hand to treat chronic pain, and that we have an obligation to do that. And we've agreed with a number of other countries, nearly 200 of them too, that we will do that, and we've agreed to that with the UN and the WHO. And also there are charter issues that may be involved when patients are getting turned away from care because of pain issues. I have the sense that that's not really on the radar much of physicians. Do you guys hear about it much?
Yeah, I don't think we really do, to be fair, because I think that although we can agree that there is some ethical obligations to treat pain, the problem is if you're not educated on how to do so, you can do it badly. So just because there is an obligation or even maybe a sense of a charter or legal obligation to treat pain, we have to make sure we're doing it safely. And in a sense, again, this is what these podcasts are about, because as you know, Dawn, I know you know this, and Dr. Kaplan knows this well, education around the treatment of acute and chronic pain is very poor in medical schools. So, we can say that philosophically and maybe, legally we understand our obligations to treat pain, but there is this important sense that we have to do it safely, and we have to do this with the proper amount of education. And that's what's been really lacking as much as anything in North America. Right.
Okay, great. Let's move on. Dr. Kaplan, maybe I will ask you again. We've addressed this previously, but let's go into it. Let's drill down a little bit on it. Should the goal of treatment, let's look at the overall goal of treatment. Should it be to relieve pain? Should it be to improve function? Should it be both at the same time? Or if it is both, should one have priority?
So, listen, we're talking about pain management, so pain treatment is, of course, the paramount thing. But we have to recognize that chronic pain is a bit different than acute pain. It's a neurologic situation. The nervous system changes. As such, the urgency to treat the pain itself can sometimes be a little different. And what I mean by that is that when we have acute pain, we have the concept of having harm occurring, and therefore making sure that we're dealing with the underlying cause of the pain is as important as treating the pain. When we have chronic pain, the underlying cause may well quite be moot at this point. It's really just dealing with the pain and the suffering of the patient at the time. However, we also have to learn to deal with some kind of symptoms that we have, and those symptoms in this case could be pain, but they could be other things such as tingling and so on with neurologic symptoms that one has to learn how to deal with, or tinnitus in someone who's got middle ear problems. And you have to learn to deal with those symptoms, because overall what you want to be able to do is live your life and continue living your life in a successful, positive way. So you have to treat the pain and treat the underlying issues and treat the surrounding issues of mood and coping skills. Along with that, all with the goal of improving function and being able to live your life in a happy, successful way.
I think to add to that, and again to your question, Dawn, and I agree with everything Dr. Kaplan has said, is that we have to recognize just like we have goals in blood pressure treatment, we have goals in the treatment of diabetes, there are some fundamental goals that we are trying to achieve in managing this population. And I would suggest that those goals are to reduce pain, to improve function, and to do so safely with minimal side effects. Now, sometimes in the past there has been this focus primarily maybe on pain intensity, reducing pain intensity, but that becomes nuanced. And we talked about this in an earlier podcast about what does that pain scale actually mean. And I think sometimes this focus on just the pain scale and the pain intensity has got clinicians into trouble. And that's why I think there's more attention being given to what can we do to improve function. Ultimately, it comes down to that question that Dr. Kaplan mentioned regarding suffering. Can we reduce our patients' suffering? And doing so means really to reduce their pain and to improve their function. Should we highlight one versus the other? Well, not necessarily so. I think that as long as both are improving, we're doing our job as clinicians. I think the problem of just focusing on pain intensity, however, is we sometimes then get into the problem of pushing medications to higher and higher and higher doses without being aware of their potential to reduce function and cause side effects. So there's got to be that balance between our therapies, side effects, and what our ultimate goals are.
Okay, thanks. Dr. Hauptman, don't go away, because it is you who has talked about the 6 pillars of pain management. I want you to tell us what they are and whether or not they have something to do with treating the whole patient. The whole patient is a concept, a phrase that we've heard, I don't know, for what, couple of decades now anyway, maybe more, that we have to treat, we don't cut up the patient into the patient's problems, but we treat the whole patient. Do the 6 pillars of pain management treat the whole patient? Tell us about them.
Thanks, Dawn. This is such a fundamental question. And really, if there's anything else people take from this podcast, it really is this understanding on these 6 pillars. And we've been teaching about this for a number of years now. It's this concept that treating pain should never be looked at from a one-dimensional perspective. For example, all I have to do is give the proper medication. All I have to do is find the correct referral to the correct specialist. All I have to do is do psychological management. It really is fundamentally looking at a broad range of therapeutic options, which we have called the 6 pillars of pain management. And very quickly, those 6 pillars are 1, lifestyle, 2, psychological interventions, 3, physical therapies, 4, interventional therapies, 5, spiritual therapies, and 6, medicines and medical therapies. Now, it's important to understand that in any given patient, there may be a better benefit derived from one or more of these therapies. But ultimately, the best managed patients are those that consider those 6 pillars of treatment and find therapies within those that apply and work for them.
That makes sense. Dr. Kaplan, do you have anything to add to that?
No, you just have to remember that it is the combination of all those things that make the managing of the whole patient successful.
I see why spirituality is in there. I'm just wondering, practically speaking, how does a clinician manage or, promote the spiritual aspect of a pain situation? I mean, just tell me, practically speaking, how that works. Do you just assess the patient to see if that's where his or her interest may lie and send them out to an appropriate, religious practitioner?
Yeah, no, I think what your question is getting at, and not only is the spiritual side, is really what are those 6 pillars. We just went over them briefly, but I think it might be beneficial to our listeners to actually kind of parry down each of those 6 pillars. So let me very quickly just kind of do that, and I'll start with spirituality. So spirituality is that sense of, who the person is, how they feel their place in the world, how they feel about suffering in general and how to deal with suffering. So it's a broad category. We all have it. We sometimes find it uncomfortable to talk about it, but even an atheist has a sense of their place in the world. We do have some data in the pain literature that people of faith, people who pray, who attend church services, are able to deal with pain and suffering better than those who don't. So that's why it's, I think, at least important to ask people about, where they're at spiritually, not something that we're necessarily comfortable doing. So that's the spiritual side of the 6 pillars. The interventional sides of the 6 pillars are things like cortisone shots, if there's a joint that's a problem or something we can inject. It may include trigger point injections. It may include the new regenerative therapies. Those are things like adult stem cells, plasma-rich platelets, platelet-rich plasma, PRP. So that's a category called interventional therapies. Physical therapies we're talking about are things like active physiotherapy, acupuncture, chiropractor, massage therapy, all can be utilized for people with chronic pain. Psychological interventions include things like cognitive behavioral therapies, ACT therapy, which is acceptance commitment therapy. So these are ways to try and rewire the brain so people experience less pain. Lifestyle, which is so fundamental, includes things like diet, exercise. Education is under lifestyle. Patients need to be educated about why they have chronic pain. And then finally, the final pillar, again, being medicines. How do we optimize the variety of medications, not just opioids, which we'll talk about specifically in another podcast, but the variety of other medications we use, like antidepressants and anticonvulsants.
Well, so it turns out that there is a cornucopia of pain therapy. Some of them might work for one patient, not another. Another combination might work in that patient, and so on. Can you break it down, now that you've laid it all out, can you break it down into categories? The first one being, which of those treatments constitutes what doctors would feel are first-line treatments? What do you do first?
Sure. I think the fundamental first thing you have to do with a pain patient is education. And most of us may not think of education as a, specific treatment, but it really is fundamental in any chronic illness, whether we're talking diabetes or asthma, heart disease, allowing the patient to understand what's going on, because patients are fearful, they're scared. They've been told by many doctors it's all in their head, that there's nothing wrong. And this fear and this stigmatization can lead to more pain and suffering. So going back, educating the patient is the fundamental first-line therapy that I think patients need to be doing. Then what we need to do is really talk again about their lifestyle, try to emphasize the importance of exercise and movement, which is, from my way of thinking, the only therapy that works in 100% of pain patients. And then going from there, really starting to individualize therapy. What have patients tried in the past? What are they currently on? Not just in medications, but also in things that are non-pharmacological. And although we've spoken about the 6 pillars of pain management, you can also divide those up in things of non-pharmacological therapies and pharmacological therapies. And that's a good thing for a family doctor to do. What have they tried in the realm of non-pharmacological treatments to date? What have they tried in terms of pharmacological treatments to date? And what has been their response to these treatments?
Okay. Dr. Kaplan, would you like to add anything there? Or maybe I could just go on and ask you, if first-line treatments don't get you much of a response, if they frustrate you and the patient, where do you go from there?
Well, there's quite a long list of things, as Rob said.
Yeah.
That's one of the things that we can work on in primary care to make sure that we've looked at all those things rather than just giving a pill, which is sometimes what happens, which may have led to us to having some of the issues we're having right now. But once you've done all those things and you've worked on them, and that's not a single visit issue, of course, this is happening over a period of time. One of the advantages in primary care is we do have the opportunity to work with the patient over a prolonged period of time. But from there, we then have to reach into stronger things into our tool bag. And this may mean interventional things like injections and nerve blocks and Botox and some of the other things that Dr. Hauptman's talked about. But then we also have to talk about stronger medications potentially to relieve the pain and suffering. That takes us into both opioid and non-opioid therapies. And I'm sure that's where we're going to go next as far as that. But remember that there are interventional things we think about, ablation therapies, things like that, to try to treat the pain and try to remove the neuropathic signal to begin with that occurs. So we have all kinds of things that happen. Some of them sound kind of scary. Doing an ablation of a nerve to get rid of the pain that's happening sounds kind of scary, but when someone's having that kind of pain, that may be a treatment that's effective for them.
Oh, absolutely. I mean, I think when someone's having severe pain, they wouldn't mind the loss of a nerve at all. They would probably, enjoy it. They would probably beg for it. Dr. Kaplan, can I continue with you and ask you to unpack a concept that we hear increasingly in the discussion about whether or not we should be hauling back on opioids for moderate to severe pain. We hear people talk about something called multidisciplinary care, or it's sometimes called interdisciplinary care. In the U.S., it's called integrated care. It's said to be a gold standard, and yet we don't seem to have too much of it around, and we don't necessarily in the literature have a lot of evidence, if any, that for moderate to severe pain, anything but pharmacological and usually narcotic therapy helps. So there seems to be kind of a cipher, a question mark over interdisciplinary care, whether it is indeed a gold standard, whether it's available. So just wonder what you have to say about that.
Okay, so the concept of multidisciplinary care is really what we've been talking about, the idea that we actually have to treat the whole patient and involve all the different components of pain. And in a situation where there is a multidisciplinary pain clinic where all these factors can be housed under one roof, the interventional issues, the psychologic issues, the pain management issues, would be the perfect situation for a patient suffering with chronic pain. In fact, that's what's recommended in terms of our new opioid guidelines, that's one of the strong recommendations that multidisciplinary clinics are used. The issue, of course, is they're just not available. We don't have them available in Canada, and our patients aren't eligible to get them because they don't exist. No one has funded them. That, of course, is what a good family doctor is going to be doing anyhow. It's going to be ensuring that we have put all these components of care into the patient's management plan so that we don't just rely on one part of it. And we can do that successfully without being a, quote, multidisciplinary pain clinic, end quote. What we have to make sure is the patient's total needs are looked after.
Okay.
I agree with Dr. Kaplan on this point. I think a primary care physician who is well educated can manage the majority of chronic pain that he sees in his practice and can direct patients to resources that can enhance what he's doing. If that can all be done in one center, i.e. a multidisciplinary center where they get education, they get interventional therapies, physical therapy, psychological interventions, I think intuitively we could say, wow, that's great. And if we had one of these in every center in Canada and in rural areas, that would be fantastic. The evidence for these centers are, as you know, Dawn, it's sparse. I have read some reports. There's not a lot of them. I did read one intriguing one that suggested an improvement in functional MRI studies of the brain in people that have gone through multidisciplinary programs. But ultimately, it's really the fundamentals of the therapies we've spoken about, whether that's given in primary care or given in a multidisciplinary center. These improve patients, and that's the good news. We really need to. We've spoken about this in earlier podcasts, but the really good news of pain management is you do these things and you utilize these tools, these treatment modalities. Most patients with chronic pain can go on to live a relatively normal life, and a relatively normal life with a good quality of life. And that's what's really exciting for me as a pain clinician.
Okay, do you think that there is a problem for a patient who is referred to interdisciplinary care, or at least can be referred to a range of clinicians and others who can, approach the patient's pain problem for a variety of angles? But let's just say that the patient who is in interdisciplinary care is not doing well with any intervention except an opiate. What do you do then? I mean, is the patient just expected to get better with the other therapies, even if he really doesn't? I mean, do you see? I'm not quite sure how to put this, but is it a standard that is not that useful for some patients, at least according to the literature? I guess what you're saying is that in practice you do see improvement, even though it's not necessarily documented in the literature yet.
Yeah, well, I think, Dawn, maybe your question is getting to the point. Is there one single modality other than education and exercise that works in 100% of pain patients? And, of course, the answer is a resounding no. There's no such thing that there's not 100% of patients that respond to psychological interventions. There's not 100% of patients that respond to interventional therapies. There's actually not 100% of patients who respond to medicinal interventions or even cannabinoids. And there's a lot of popularity out there now with the medical cannabinoids and medical marijuana, but I've seen people fail that. So I don't want clinicians out there who hear this broadcast to believe there's this, cookbook approach to chronic pain. And in particular, if a patient fails some of these other therapies, that they're somehow to be blamed or that they're not doing enough. Because there are patients who do wonderful with our medications. There are patients who do wonderful with interventional therapies. There are patients who do wonderful with psychological interventions. But it's too narrow to say that we should approach all patients with the same cookie cutter.
Thank you. That was what I was asking. Thank you. Dr. Kaplan, I want to look just very briefly at what family physicians should keep in mind when they're treating comorbidities, when they're treating chronic pain and comorbidities.
So when we choose our treatments, we want to ensure that this treatment is efficacious, first of all, but safe, second of all. And some of the medications we use can have drastic effects on other issues. A couple specific examples are if someone has a problem with sleep, then we want to potentially use a medication that's going to both help pain and sleep at the same time. An example of that may be a tricyclic antidepressant, for instance. If someone has an issue with obstructive sleep apnea and we use an opioid therapy, well, that could be a real problem because it could worsen the sleep apnea. And if someone's not being treated for it, could get them into trouble with manifestations of the side effects of obstructive sleep apnea. So we have to be considerate of the fact that, again, as a whole patient, they've got other issues going along with it that we have to be careful about. Another example is somebody has bipolar illness, for instance, and wants to use an antidepressant like a duloxetine for pain management. That might induce mania and could also be a downside. So every medicine we use has a potential for adverse effects and therefore can affect the comorbidities that a patient may have. Sometimes even the counseling that we do can unlock other problems, such as past sexual abuse and things like that in the end is a good thing to have been talking about, but may cause quite a bit of pain and trouble in the middle of working through with that particular individual. So I guess what I'm saying, Dawn, is that the patient is a complete patient with multiple different issues, and we have to respect those issues as we go ahead treating the pain as well.
So, Dawn, not only do we have to recognize what other comorbidities they have in terms of their general health conditions, I think it's also important to emphasize that we have to also recognize the secondary comorbidities that can happen as a result of the chronic pain. So we know people with chronic pain have a higher incidence of mental health problems, particularly things like depression, anxiety, and PTSD. If we're not addressing those in our treatment, that can make the pain worse. And I think all our audience can recognize that people who have significant mental health problems, not just frustrated with the pain or feeling discouraged about having pain, but rather have a DSM-5 diagnosis of depression, anxiety, or PTSD, this is going to ramp up their pain. So recognizing mental health comorbidities is important. Recognizing personality comorbidities are important because all these influence how successfully we are going to manage the patient's pain. So using tools like the PHQ-9, which screens for depression, the GAD-7, which screens for anxiety disorders. There's also a PTSD screening tool. All these things are important in assessing people with chronic pain. we can certainly put links to these tools in our show notes.
And of course, the other comorbidity that we haven't mentioned is the concern about what's on everyone's mind is the addiction risk. And this has to be looked at as one of the initial reviews before you start somebody on medications that can have issues with misuse.
Right. Dr. Hauptman, can we go back just briefly to the comorbidity that you mentioned, depression, a form of mental illness? There are, I'm sure you've run into them, there are patients out there who are reacting in a way that I would call appropriate to chronic pain that's changed their lives. You know, maybe they've lost a job, they haven't been able to keep a job that they love and that they depend on to keep their families afloat because of their chronic pain or something like that. So the patient can be quite devastated without going into a depression or becoming mentally ill. And I hear from patients that almost always now it's assumed that a patient who has chronic pain is depressed. And in fact, our guideline, the prescribing guideline for opioids that came from McMaster last year, actually say treat the depression before you treat the pain, which seems odd to me. I'll just use the word odd. I guess my question is, how do you keep patients from feeling that you suspect them of depression, mental illness, when what they're feeling is entirely appropriate from their point of view?
Yeah. I think, if you ask pain patients, are they frustrated? Are they discouraged? Are they unhappy with their pain disorder? 100% of them will say yes. I think that's pretty obvious.
Right.
However, the best reviews that I have seen suggest only about 20 to 30% of people with chronic pain suffer from a major depressive disorder. So that takes it to another level. I mean, this is a DSM-5 diagnosed depression, not just feelings. We all have feelings. People without pain have feelings. I mean, it's pretty obvious. But we have to be careful, as you pointed out, to not diagnose every single patient who has pain as being depressed. That's overdiagnosis, clearly. But at the same time, we have to be aware that if they do meet the criteria for major depressive disorder, that we recognize it. I, like you, believe that you should be able to treat depression and pain at the same time, recognizing, however, that untreated pain makes a major depressive disorder worse, and untreated major depressive disorder makes pain worse. So it's this cycle that kind of goes in the circles. We have to recognize and treat both.
I think that's accurate. I would just jump on my soapbox for just a sec and point out that because we are getting into having a crisis of undertreated or untreated pain in this country, when there is an episode, I remember there was a suicide last year in Winnipeg. A man had been in an ER with significant pain. I think it had gone on for months, and he just couldn't get it treated. And when he was ejected from an ER without treatment a final time, he killed himself. And when this was reported in the press, it was very clear that the man killed himself because he had atrocious, untreated pain and had so for ages. Immediately, the press turned it into a story about mental illness, and I see this going on particularly in the American press all the time. So I just wanted to point out that this is becoming a problem in the media. It's becoming a political problem, and if it can be curtailed in the doctor's office, that would be useful. Anyway, that's just my observation. I wanted to talk about the situation in which the family physician has got his pain patient under control, to some degree stable, happy. Is there an accepted protocol for follow-up, and what is it? What does it involve? Dr. Kaplan, I'll ask you.
Sure. Well, just to finish up the comment about pain and depression.
Okay, sure.
I think it's also really important just to remember what you've been saying here, which is the concept of labeling. Doctors, we have a bad habit of wanting to fit people into buckets of diagnoses because we know how to treat them that way. And as Dr. Hauptman's already said, it's a complicated situation dealing with someone with pain because it's not a simple cookie-cutter approach, and we have to make sure not to label our patients and expect them that way. I also do some work in a psychiatric facility, and I can tell you that I do see people get admitted to hospital with suicidal ideation because of pain, and our guidelines do say treat the depression before the pain, but in fact, if you don't treat the pain, you can't treat the depression, and I think it's a really important factor to be said.
Sure. Yeah.
As far as follow-up and patient in the office, it actually does not have to be terribly difficult. In fact, these are patients that can be done in a very efficient way. We use a couple of tools to assist with this, and Dr. Hauptman's already mentioned the tools as far as mood, PHQ-9, and anxiety with GAD-7. We want to talk about the level of functioning and the level of pain, and we can do that with something called the brief pain inventory, which gives us a measurement of both pain and functionality. Pain from 0 to 10 in the visual analog scale, and functionality in 7 questions, and a Likert score from 0 to 10, giving you a score out of 70. There's also a nice tool that we created called the 6 A's, and this is a charting tool that talks about how you see a patient from visit to visit. And the A's include, first of all, A for analgesia, where your pain is from out of 10, and in no particular order. A for adverse effects, how you deal with those in terms of things like constipation and nausea and cognitive issues and comorbidities and so on. A for addiction risk and concern about that, and aberrant behaviors, anything to use along that line. A for assessment in terms of goals and functionality. Are you able to do your activities of daily living? Are you able to live your life? A for, again, addiction risk in terms of urinary drug screens as appropriate for patients. And then A for affect, which is also important there in terms of saying how are we coping with this? Not necessarily full DSM-5 criteria, but in fact how are you actually coping with your pain and with your stability and with the change in your life you've had to live with because of your chronic pain.
So is it fair to say that a physician can expect the patient to change over time, or do patients generally just become stable and these indicators, mood indicators and function indicators and that sort of thing, do they change over time? I mean, what's the usual thing that you see, if there is a usual thing?
Well, there is no usual thing, but their goals of therapy improve in all modalities. That's what we'd all like, everything. And we treat diabetes as a chronic illness. We want the A1C to go better and the lipids to be better and the blood pressure to be better because we know in the long run that's going to prevent bad outcomes. It's no different when you're managing chronic pain as a chronic illness, hoping to be able to manage these issues to improve things. Now, the reality is the disability that occurs with someone who's had a bad accident may not improve physically, but emotionally, are they able to cope with this better and able to do more because of the pain modalities we've introduced, as an example? So the BPI score, hopefully, with time, does improve because hopefully the pain is stabilized and the ability to cope with it and function does improve over time. And similarly, the mood scales and the anxiety scales will also get better. Sometimes it's just the patient recognizing that there's a doctor around who's working with them to try to help them can go miles in terms of helping their ability to cope because they know they have an ally against this menace of chronic pain.
I strongly believe, Dawn, that with proper therapies, the majority of people with chronic pain do improve over time. However, that's not to say that people are cured. This is a permanent condition in the 21st century. There is no known therapy at this point in our understanding of medicine that cures chronic pain. So I think it's important for clinicians to recognize that this does become a chronic disease management issue in the same lines as Dr. Kaplan mentioned, as diabetes, as asthma, as heart disease. So regular routine follow-up, I would suggest every 3 months is very important. And again, I cannot underemphasize or overemphasize, enough the importance of clinicians maybe checking out the follow-up tool called the 6 A's because it makes the reassessment of these patients more standardized and easier to do. And again, we will put a link to the 6 A's in the show's notes.
Thank you. That's great. Dr. Hauptman, Dr. Kaplan, once again, you've told us what we need to know. There you have it. Thanks very much. Family physicians shouldn't be afraid to treat chronic pain, it turns out, according to Dr. Hauptman and Dr. Kaplan. The process can be challenging and rewarding, and it can be a challenging and rewarding experience for both you and your patient. And as we've heard, it is a complicated process. It involves maybe quite a lot of trial and error. It involves careful observation, active listening. And it's good news that there is a proven process with tools to implement it which Dr. Kaplan and Dr. Hauptman have now walked us through. Join us next time when our team is back to talk about the million-dollar question: opiates for chronic pain management, yes or no? I'm Dawn Rae Downton. See you then.
Thank you for listening. If you like this episode and want to hear more, please visit www.MDBriefCase.com and subscribe to the Get Brief podcast channel. Tune in next time for another exciting episode.